Paul, and good afternoon, everyone. I know it's after 3 and we've had so many wonderful presenters and so much incredible information, but really hang on with us a little longer because I'm so excited. And really, it's my extreme pleasure to be introducing our next presenters that will be highlighting their low threshold BUPE programs. So first to present will be Jerry Otero and Dr. Bruce Trigg talking about their work at St. Anne's Corner of Harm Reduction. Jerry Otero is the coordinator for the Drug User Health Hub at St. Anne's Corner of Harm Reduction. Jerry is trained as a bilingual psychotherapist committed to supporting the healthy development of our most at-risk youth. His work is really driven by the belief that marginalized young people heal from the impact of racial and economic suffering when they comprehend and address the complex hidden social and economic forces fomenting their everyday challenges. His approach to working with young people attends to their safety first, is reality-based, and respects youth's inherent intelligence and capacity for critical thinking and free will, all while empowering them to be actively engaged in a new kind of civic action, to be a force in changing the circumstances that trouble them instead of simply being the passive recipients of traditional youth development services. The focus on teaching them how to work around the injustices they experience day to day in their lives as second-class citizens. In addition to his work at St. Anne's, he has held positions at the Drug Policy Alliance and the Partnership for Drug-Free Kids. Dr. Bruce Trigg will be presenting with Jerry, and Dr. Bruce Trigg is a medical provider at St. Anne's Corner of Harm Reduction. Dr. Trigg is a pediatrician and public health physician. He worked for 23 years with the New Mexico Department of Health, where he helped to establish one of the first statewide harm reduction programs in the US. He was a part of a multidisciplinary perinatal substance use program that continues after more than 25 years. He was a leader of the effort to start a methadone maintenance program at the Bernalillo County Jail in Albuquerque. Dr. Trigg worked as a clinician in buprenorphine and methadone treatment programs in New Mexico. He's been a national advocate for providing medication for addiction treatment for incarcerated populations. He worked as a global MAT consultant in Southeast Asia from 2013 to 2016. Dr. Trigg now lives in New York City, where he is a consultant with the New York State Department of Health, AIDS Institute, Office of Drug User Health, and consults nationally on MAT. Dr. Trigg graduated from the George Washington University School of Medicine. He did his pediatric training at Albert Einstein College of Medicine in New York City and the University of New Mexico. He worked for 3 years as a general medical officer in the Indian Health Service in New Mexico and Arizona. And then next we'll ask to present Katie Fee. Katie is a registered nurse based in New York City. Currently, she is the nurse care manager for Drug User Health with Project Renewal. In this role, she provides patient-centered support to people who use drugs and are precariously housed with a focus on low threshold access to medication for opioid use disorder. Prior to working with Project Renewal, she worked in HIV care and prevention at New York Presbyterian Center for Special Studies. Katie graduated from Johns Hopkins University with a bachelor's in nursing. Thank you so much, Jerry, Dr. Trigg, and Katie. And without further ado, Jerry and Dr. Trigg, the floor is yours.
Okay, can you see my screen?
Yes.
Everyone can, great. Hi, everyone, very excited to be here. What a great panel, a great set of panelists. And we're gonna, Bruce Trigg and I are gonna add our piece to it. We're gonna get through this as quickly as we can, but wanna make it as meaningful for everyone as possible. I run the Drug User Health Hub at St. Anne's Corner of Harm Reduction, located in the Bronx. Utilizing an evidence-based public health model, SACHR, St. Anne's Corner Harm Reduction, provides immediate client-centered public health medical care and access to BUPE treatment. Our clinical practice is informed by the use of practical harm reduction strategies that are aimed at working collaboratively to reduce the negative consequences of opiate use, including overdose and other drug use-related harms, without requiring total abstinence. So many of our folks today emphasize that, but we do too. SACHR's philosophy of caring for people that champions meeting them where they're at provides the underpinnings for the low threshold buprenorphine services that are offered through the agency. We're committed to providing our program participants low threshold services that include same-day initiation of treatment. The model features the use of a harm reduction approach that's fully integrated into the workflow of the agency, and that's a very important piece. It's not the other way around, as in so many places that our participants have frequented before looking for services. Here, services are provided in the neighborhood where is the highest need. We're in the Bronx, but yet where flexible program requirements may not be otherwise or typically found. The hybrid model that we've embraced includes pharmacological therapy, psychosocial services, integration of care, and education and outreach, but none of that's required. It's really left up to the participant to sort of drive the bus and let us know what it is that they need for us. We try to make it available. We try to make as much as available to them as possible. We borrow heavily from the office-based treatment model, which was discussed earlier on, and to a lesser extent, a one-stop shop model that provides integrated care, including the management of HIV and Hep C infection, as well as other services, including syringe exchange, a drop-in center, hot meals, showers, and so on. Low threshold doesn't mean no threshold, but Satcher's history of providing non-judgmental and person-centered services has characterized the agency for more than 30 years, and it's one of the reasons why stigmatized populations routinely seek the help and services that they require and deserve through Satcher. We offer a full range of non-judgmental quality access to healthcare resources that seeks to counter social stigma that's attached to our program participants' illicit drug use, HIV, and Hep C status, poverty, race, gender identity, homeless, or other health issues that undermine other health or social issues that undermine their ability to access services. Special attention is given during the brief intake and assessment process. And if you look over to the left of the screen, you'll see a whole host of things that we consider wraparound services that we make available to our Butte patients. But the intake process is a brief one that seeks to, undo some of the power dynamics that exist in some of these kind of relationships, but that seeks to develop a holistic understanding of the individual's presenting life circumstances across a number of dimensions, rather than just relying on sort of a reductionist approach that ties a person to a diagnostic category or reduces them to a discrete set of problems to be addressed separately. As I mentioned, we're in New York, where overdose death rates are the highest now than they've been since we began reporting these deaths in 2000. How the hell could this be? Given all the media attention and the campaigns to raise awareness, how can it be possible that overdose rates have doubled since 2016? It's kind of like it's deer season and we're the deer. As I mentioned, we're in the Bronx, and on this slide, you'll see that the top 4 neighborhoods in New York City for overdose deaths, which are more like drug contamination, but we'll talk about that another time. The top 4 neighborhoods are square in our backyard, and drug use fatalities are, it's criminal. Quick other slide to drive the point home. One of our medical providers, Bruce Trigg, you'll meet him in a moment or two, lives in the Village. And as you can see, the disparity between neighborhoods here is striking. And here, this chart illustrates a difference between certain neighborhoods here in New York City. One of the top reasons that people with substance use disorders don't seek treatment is that they may not be ready yet to practice abstinence. And substance abuse is the only field in human services where the client is required to give up his symptom before entering treatment. Satcher lowers this threshold so that people who are unsure of what to do about their drug and alcohol use can have access to treatment. Low threshold Bupe is unique in that it makes explicit from the very first contact that everyone is welcome, regardless of their stage of change, their relationship with drugs, or their goals for future use. Low threshold, first and foremost, stems from our willingness to work with clients who are still using, and it exemplifies the belief that clients can always be engaged in working to improve themselves and their circumstances. No one is unmotivated. Person's decision to walk in the door is interpreted as a sign that they are motivated. The question of motives is better posed as to what is the person actually motivated for? And this is what I think causes a lot of conflicts between service providers and the clients of those services, is that they're under that we fail to understand what they're motivated for and what that level of motivation is, their desire, level of self-efficacy, their readiness, problem recognition, and other factors. At Thatcher here, we work with people to first take the actions they're most motivated to take first, and then continue to work with them toward new goals that may present themselves later on. Most recently, we were awarded a substantial grant from the New York State OASIS, funded by the opioid settlement monies that will allow us to double our capacity. Over the last 3 years, we've provided BUP services for over 300 patients, most of which stick around for between 3 to 6 months. And we could talk about how people cycle in and out of so-called recovery. Lastly, however, I'd like to say that we've also started issuing medical cannabis cards, which has been a resounding success in our setting. And the best way to illustrate where the rubber meets the low threshold road is to turn to Bruce Trigg, our lead medical provider, for a case study. And Bruce, if you turn your microphone on and your volume down, you can take it away from here.
Great. Thank you so much. Yeah. Thank you, Jerry. I'm delighted to be here and enjoyed all the presentations today. I've been riveted to my computer. Yes, so I just want to say for about 20 years, I've been trying to integrate harm reduction principles into the medical settings where I've worked. Health departments, behavioral health programs, medical clinics. And I've had the great experience in the last 2 years that I've been working at St. Anne's Corner of being in the opposite situation where the whole setting is harm reduction, and we've been trying to integrate some medical interventions into that. So it's been a learning experience and a great pleasure for me to do that. So here's a story about a patient who, like all of our patients, we have great concern about. A young woman who was brought to us by a peer worker in the Relay program in the Bronx, which she had overdosed, was brought to the emergency room, and was discharged with a referral to Relay. And this peer worker brought this patient to Thatcher. And this was in November 2021, in the height of the COVID pandemic. She was started on buprenorphine, and unfortunately, we later learned that she had some problems with her Medicaid, and she wasn't able to pay for the medication, but she was buying it on the street. She did continue her medication, and by the time she called us again, she was working a full-time job. She called us on her coffee break at the job and said she'd like to resume the medication. And of course, we told her we'd be delighted to do that. We renewed her prescription with a plan for her to come to Thatcher within a week or two. Next slide, please. Yes. So then once again, unfortunately, we lost some contact, but she called us again and we had a FaceTime conversation. Again, she was at work full time, and the understanding was that we'd renew her medicine for a week, and she would try to come and see us in person a week later. So basically, very patient-centered. Woman had a full-time job, and like many full-time jobs, unfortunately, the ability to take sick leave or leave time for medical purposes is quite limited. And we wanted to, we certainly didn't want to interfere with her employment. So we were able to be flexible with either FaceTime calls or even just telephone calls, which of course became possible during COVID. She told us that the 12 milligrams wasn't adequate. We increased the dose to 16 milligrams. The next time, let's see, next slide, please, Jerry. The next time, the next time we saw her, she asked for a refill. If she asked for a refill over the phone, the pharmacy wouldn't refill it because the previous prescription was still active, and it turned out that she was taking three films a day instead of the 2 that had been prescribed to deal with her anxiety and what she perceived as withdrawal. So we tried a clonidine and another increase in her dosage. Sometimes people don't really need necessarily more medication; they need more time to be stabilized. And clonidine, we often find, is a helpful adjunctive medicine. But in fact, she didn't take the clonidine, and the next time we saw her, we increased her dose at her request to 24 milligrams a day. Around this time, some of her untreated and really undiagnosed other mental health problems like anxiety and panic attacks became an issue, especially during the stress of COVID. She was having panic attacks in the subway on her way to work, and we tried to refer her to a psychotherapist and to a psychiatrist, and I prescribed hydroxyline for her, which she did found helpful at the time of some of these panic attacks. Around this time, we offered her a medical cannabis card because she said that in her experience, smoking cannabis helped with some of her anxiety and her cravings. And I'm fortunate to be certified to provide these cards. And as Jerry mentioned, this has been very, very popular among our patients, and I'm very happy to provide this. By the way, she had also lost her sense of smell, perhaps from COVID, and was having, was losing weight. So that was another very good reason for cannabis. And then she went on vacation for a while to Florida, and we lost contact, but she was able to come back at least once. That's a noisy vehicle on 10th Street. And when she came back, she reestablished treatment with us, and said she was using Xanax and oxycodone that she was purchasing on the street. And of course, we discussed with her the very high risk of sorry about that. We discussed the risks of contamination and actually replacement of oxycodone and Xanax, often by fentanyl. So at this point, we did another initiation of treatment, and I'm currently using what I call macro dosing of up to 32 milligrams on the first day, and unfortunately, we haven't heard back from her since that attempt at reinitiating the medication. I also prescribed clonidine, ondansetron, hydroxyzine, and loperamide. Next slide, please. So this is, a typical story, and one that I'm sure everyone on this call, this type of has had similar experiences with patients who have very difficult lives. and are in and out of treatment. And is this a success or a failure? And, you know, this young woman is alive, and she knows that we're always happy to see her and willing to do our best with her. And I consider this a success in a very dangerous and a difficult world that we're living in now. We never give up on our patients, and we try our best to provide patient-centered care and provide support, other supports that we can have, social work supports and referrals to psychiatric care, for example, when needed. Next slide, please. We always provide medication when a patient contacts us to get them to the next appointment. We never turn people down. We're not happy about calls at 4 p.m. on Friday, but we still do our best to work with people. Jerry carries a cell phone, and all patients are given that phone number. As far as I'm concerned, giving people a voicemail system with complicated, numbers to push to try to get care after hours is not adequate. And frankly, I think it's really dumping a patient a patient who's initiating treatment, the risk of a precipitated withdrawal is of course always there. And I think it's really sort of dumping a patient to have them go to an emergency room. I think it's really vital that we do almost all home inductions. In fact, we do all home inductions. It's really important that backup be available to patients, and having someone with a cell phone available, I don't think that's an unreasonable demand on our programs. But that's my editorial comment on that. We offer lots of adjunctive medications, and we don't really know how much of it's placebo, but it certainly gives patients some sense that they have control over their symptoms, and it also shows, I believe, our concern for the patient's well-being. Next slide, please.
Why don't you talk for a moment, though, about the options that we offer people in flexible initiation sort of protocols?
Oh, yes. Yeah, thanks for pointing that out. So yes. So as the previous presenter, Dr. Hayes, was very clear about that, that there are challenges now to doing initiation, and there's been a lot of concern about this among providers. I was recently at the National ASAM meeting, and there was a packed workshop, probably 1,000 people discussing these issues. And ASAM is working right now on a publication that will give some advice. They're not calling it a guideline because the scientific studies aren't really there yet. But at this point, I think there's enough information accumulated that they can provide some recommendations. But we do discuss with patients the possibility of what used to be called microdosing or low dose initiation, where people can continue the opioid, whether it's methadone or street drugs that they're using. And we've also, by the way, like Dr. Hayes, have not been successful yet with offering this low dose initiation. We also offer what I think would be called the standard induction, and then some of us are doing macro inductions. I already mentioned up to 32 milligrams on the first day, and I think that shows quite a bit of promise. And here's a slide from that ASAM presentation where they said the kick pack is back. Kick packs were what people were given before buprenorphine was available for withdrawal from opioids. It is not adequate treatment, but on the other hand, some of these medicines do in fact offer assistance with some of the symptoms of withdrawal.
And I'm so sorry, Dr. Trigg, to jump in. I just want to be sure that we have enough time to kick it to Katie too. This is absolutely wonderful information. I just wanted to give you that time check.
Well, that's serendipitous because that was our last slide. Bruce, why don't you tell us the good news, and then we'll kick it over to the next speaker.
Yes, I have some excellent news, and we're very excited. It was mentioned that the first 2 legal overdose prevention centers in the United States were opened in November 2021, and Satcher is now preparing to open a overdose prevention center. So, the fact that the 4 highest rates in the city are in the Bronx of overdoses, it's really important that we be able to provide this in some of these really hard hit communities. And Satcher is going to be probably the next one in New York City.
And there you have it, folks. That's our story. We're sticking to it. Thank you so much. Thank
Very,
you,
Dr.
Bruce.
Trigg. Thank you so much. This was wonderful. Katie, let's pass it to you.
That's such exciting news about Satcher. I'm really excited for you all. I don't have any slides, so you'll just hear me kind of chat about my work. I am a nurse based in New York City. I'm the nurse care manager for drug user health at Project Renewal in New York City. Project Renewal is unique in that it's primarily a housing organization. They run a number of shelters throughout the city in all 5 boroughs, as well as transitional housing and supportive housing, and crisis services, including OASIS licensed treatment programs. And part of Project Renewal's mission is to integrate medical care, vocational training, and supportive services into these housing programs. And I'm part of the medical team, and specifically the drug user health team. And I think similar to what other folks have mentioned, our drug user health team really recognizes the unique healthcare needs of folks who use drugs and the specific barriers that folks who use drugs experience. We've talked a lot about stigma and negative experiences with traditional healthcare systems. Folks also experience barriers related to their immigration status or racism, as well as physical barriers, whether they're, their ability to travel to a clinic, access to a cell phone, challenges that come with being precariously housed, their proximity to the clinic changing, how they're able to access care. And so part of the drug user health team, our goal is always to reduce those barriers as much as humanly possible. And I think that is incorporating harm reduction into not only the healthcare team and doing harm reduction trainings with the healthcare team, but really training folks on the housing side around harm reduction as well, and trying to address those physical barriers. We provide care regardless of somebody's insurance status. We connect folks to Medicaid transportation. We provide Metro cards for folks to travel throughout the city. And the peers that I work with in the drug user health team help connect folks to help folks access cell phones and things like that, so that really we can utilize as many tools as possible to help folks stay connected to care. And I think Project Renewal is really uniquely positioned to provide low threshold care to folks who use drugs, because people who use drugs are already utilizing so many of our services, whether they're living in some of the supportive or transitional housing or within our shelters, or they're utilizing services on our medical van that does street outreach and medical care, or they're connected to our peers doing street outreach. There is often someone from the Project Renewal team who is making some type of warm engagement, warm connection to patients and to people who use drugs. And from that warm engagement, our model has really been centralizing support through me for folks who use drugs as the nurse care manager for drug user health. So all of our team, both the drug user health team, like the peers, as well as the healthcare team, whether that's like the staff nurses in our embedded clinics, or the residential aides in the shelters, or the occupational therapists at supportive housing, they're all aware that if they meet someone who expresses some need related to their substance use, they can call me directly to triage. And in my role, we're really patient-centered and help the patient identify whatever their goals are around their care, whether that is accessing medication such as methadone or Suboxone, accessing treatment for HIV or Hep C, accessing safer supplies, providing education on safer use, or admission into a stabilization program if that's something someone's interested in. But we really work to recognize, to have those goals be patient-driven and those opportunities and options be patient-driven and identified. And similar to what some other folks have said, some of the tools that have really helped us be able to provide this level of creative and patient-specific services. I think reducing the unique barriers that each patient experiences has been not only having it central, like having this care centralized, but also through our community partnerships. We partner with a methadone program that has really committed to having next day appointments available for folks that we refer. In our clinics, we always have a Suboxone provider available to either do a same day evaluation or provide bridge prescriptions to folks, whether it's an established patient, a patient who's returning to care after a period of incarceration, or just as the St. Anne's folks, their case study so wonderfully showed, folks who just kind of get lost to follow up after a bit and then kind of turn up again, making sure they can still access care. And then or even new clients who might not be able to come in but have worked with me and will connect around induction protocols. Similarly, working through whether someone might benefit most from a micro-induction, standard induction, or macro-induction, really tailoring it to the unique needs of a patient. And similarly to OnPoint, partnering with a pharmacy that always has Suboxone in stock, is willing to break a box, is willing to really work with us and with our patients to help folks access what they need and have it be as individualized as possible, to reduce the unique barriers that our patients experience. Like I said, I think if I could just make a plug for nurses, I think nurses are uniquely skilled at triaging and assessing a situation and really connecting and developing trust with patients. And that's really benefited our population to develop relationships over time. And for our patients and our team to know that I'm always available and will work with folks to find a solution to whatever their needs may be and can make that connection for people, has really proven beneficial to many of our patients, and has allowed us to continue to provide low threshold Suboxone and connection to methadone and Hep C treatment and stabilization for folks. It's been really great.
Thank you so much. Thank you so much, Katie. Thank you so much, Dr. Trigg and Jerry. I really love that you all highlighted challenging what patient successes look like and focusing more on the success that a person is always welcome and can receive that life-saving care.